This is a video case presentation of a 24-year-old female who presents with normal, healthy gingiva. Outwardly appearance is it is pink, knife-like, no bleeding upon probing. You can see that there's stippling in the gingiva. For the most part, everything looks really healthy. This is the data taken from her perioprobing and clinical attachment loss. You can see there's not a lot going on here either. Number 30 has got a cal of 6 with a gingival margin 5 millimeters and a periodontal depth of 1 millimeter on the lingual. Radiographic examination shows more of the same. Outwardly it appears normal and in fact healthy. There's really no vertical bone defects, loss of bone structure or circumferential defects that can be seen anywhere on the x-rays. However, when you use a microscope to help diagnose periodontal risk, it's a completely different story. What you're looking at is a phase contrast microscope view at 400 times magnification, and it's a very diseased mouth, and of course the infection always precedes the symptoms or the loss of attachment, recession, and bone loss. And there's a lot going on here. She's got white blood cells fighting the infection, loaded with spirochetes, which has holistic ramifications that exceed just the gum loss and bone loss that we would obviously see in the mouth as dentists. But obviously, as we move this slide around and look at the plaque sample, you can see she's teeming with spirochetes, too many to count, and she reports at least brushing once a day with over-the-counter products. This definitely illustrates the importance of using something in addition to just a perioprobe when you're evaluating patients periodontally. So without looking at a microscope, how long would she have this condition before anything was really addressed here? In all reality, it would probably be way after the fact. So what the patient elected to do was to have CO2 laser therapy, where we treat her gums around the necks of the teeth, and basically I'm just walking CO2 laser around the crest epithelium, because as it heals it invaginates inwards into the pocket. I'm going to do that on the lingual, do it also do it on the buccal and the lingual. Basically what I'm doing here is I'm just making little overlapping circles as I kind of traverse the necks of the teeth, and then I'm going to go back in and I'm going to sink my the tip of the laser into the sulcus and just kind of slowly walk it around the sulcus while I'm engaging the laser, letting the energy from the laser just penetrate into the pocket depth, where it's going to really evaporate tissue, gingival tissue, as well as spirochetes and their cysts, cyst form obviously. And I'm just showing this lower left quadrant here, but you're going to do this for the full mouth obviously. This is our post-operative slide. We're viewing a phase contrast microscope slide at 400 power. You can see there's some red blood cells that are in various places, a little bit of an air pocket there in the slide. And I can see a little Brownian motion of some debris there, but I'm not really seeing the spirochetes anywhere on the slide post-operatively. And so this is a repeat of a case presentation that I did where basically I did the same thing, used a number of detergents and astringents to get rid of the spirochetes, such as oil pulling and baking soda, and nothing really got rid of them. They kept coming back. And so here we can see that we repeated our results. There's really nothing going on here. The slide is dramatically different. So that is two different patients with the same result and technique. Thank you for watching.